Good morning. I'm back at it, and now we are on section 9. So, section 9 is the last book of the Pocket Guide for Lactation Management by Karen Cadwell and Cindy Turner Maffei. There are other portions of this that uh, that are in the back of this book. There are appendices. There are 26 appendices. So section 9, while it's the last section, there are still all of those appendices to get through. So, but you've gotten through a substantial portion of the book, which is great. And so now we're at section 9. Section 9 is nursing possible. National and international health authorities concur that lactation is possible for virtually everyone who gives birth. There are very few maternal and infant conditions that preclude breastfeeding. See Appendix Q for a current list. Yet the families of breastfed families often worry about the appropriateness of human milk for their little ones. In this section, we address some common questions families ask. This information is accurate as of the revision date of this book, but it's always best to consult an up-to-date resource for more information about these conditions. See Appendix Y for trusted medication resources. Concern: smoking and breastfeeding. Descriptor: use of tobacco cigarettes when breastfeeding. Concerns have been raised about whether components of cigarette smoke can be found in breast milk and what effect this might have on the baby. Unique identifier: concerned about choosing to breastfeed if smoking cigarettes. Ask yourself, is the family aware of the need to protect the baby from all secondhand smoke? Was there smoke during pregnancy? If so, breastfeeding should be encouraged and the baby should be protected from secondhand smoke. Research indicates that breastfeeding may mitigate the adverse effects on the child's cognitive development of smoking during pregnancy. Cutting back on the number of cigarettes smoked can result in a better weight gain if this is an issue. Smokers may find some cigarettes more important than others, the first of the morning, after a meal, etc. Cutting out cigarettes at other less important times can be easier. If there is motivation to stop smoking altogether or to cut back, a smoking cessation program might be a solution. A prescriber may suggest nicotine patches as a choice during breastfeeding for those who want to stop smoking. Nicotine gum does not lower the blood levels of nicotine as well as the patch does, and some may have fluctuations in blood levels not seen on the patch. Nicotine from a nicotine inhaler results in lower levels than inhaling cigarettes. Watch out for fussiness. Babies of smokers may be fussier than other babies. Smokers tend to nurse for fewer months than non-smokers. Smokers may make less milk than non-smokers, possibly due to lower prolactin levels. What to do about it? It is accurate to say that tobacco components can be found in milk, but the greater exposure occurs with smoking during pregnancy and or if the baby is exposed to secondhand smoke. Cigarettes are very addictive. It may not be realistic to expect a person to give up smoking in order to breastfeed. Smoking cessation programs can be very helpful. The benefits of receiving breast milk, even from a smoker, outweigh any negatives. For all families, emphasize the importance of protecting the baby from secondhand smoke. Suggest options for reducing or stopping smoking. Ensure frequent nursing and other good breastfeeding practices. Be familiar with local tobacco cessation resources and ensure appropriate referrals. Ensure frequent weight checks for the baby. Help the family with the baby's fussiness if that becomes an issue. Expected resolution. Smokers should be encouraged to breastfeed if that is what they desire. Babies must be protected from secondhand smoke no matter how they are fed. In our opinion, more effort should be expended on helping parents understand the importance of protecting babies from secondhand smoke and the disadvantages of formula feeding than on the possible cigarette toxins conveyed to the baby via breast milk. Concern: over-the-counter or prescription medications being taken while breastfeeding. Descriptor: safety of medications when breastfeeding. Most medications likely to be prescribed when nursing have little effect on milk supply or on infant well-being, although there are some categories of drugs, such as anti-metabolites and street drugs, recreational or illegal substances, that are always contraindicated. Radioactive compounds usually require a temporary cessation of breastfeeding that varies according to the compound. Medications, including prescription and over-the-counter preparations, as well as vitamins, nutritional supplements, and herbal remedies, should be checked with a reliable source. The United States National Library of Medicine maintains LACMED, a peer-reviewed and fully referenced database of drugs to which breastfeeding parents may be exposed. Among the data included are maternal and infant levels of drugs, possible effects on breastfed babies and on lactation, and alternative drugs to consider. Appendix Y. NB. As of December 2019, the LACMED smartphone application is no longer being updated and thus should no longer be used. But the LACMED database housed on the National Library of Medicine's NCBI virtual bookshelf continues to be updated. The reference book, Medications and Mother's Milk, written by Thomas Hale, PhD, is a comprehensive reference on the impact of currently used medications on breastfeeding dietes. Updated biannually, this resource has an easy-to-use lactation risk rating system. The Infant Risk Center is an internet and telephone resource based on Dr. Hale's work. From time to time, the American Academy of Pediatrics publishes a list of prescription and non-prescription drugs indicating their compatibility with breastfeeding. Unique identifier: the name of the medication or substance, dosage, route of administration, age of baby. Ask yourself, if the medication is one that is of concern while breastfeeding, can a different, more appropriate medication be substituted by the prescriber? If the medication is of the long-acting type, can a short-acting one be substituted by the prescriber? If a contraindicated medication has been prescribed, what plan can be made to keep up the milk supply or help with weaning? What is the plan for feeding the baby? Watch out for recommendations that are not evidence-based because of the mistaken idea that breastfeeding is impossible. Encourage checking each individual medication every time with a reliable drug safety source. Individuals not taking prescribed medication because it is thought to be contraindicated without consulting with a trusted drug safety resource, or taking less of the medication than is indicated to achieve the desired result due to concern about its effect on the baby. Assuming that drugs that are considered safe during pregnancy are also safe during lactation. This is not always the case. Babies who have otherwise unexplained behaviors which may be associated with the medication used by the lactating parent. What to do about it? Ensure appropriate resources for families and prescribers to this evidence-based decisions can be made. Expected resolution. With few exceptions, breastfeeding and medication are compatible. What else to consider? Changes in milk supply. For example, pseudoephedrine has been shown to reduce milk supply. Baby behavior. Some drugs, such as tricyclics, accumulate over time and may make the baby progressively more drowsy and sleepy. Other effects on the baby. For example, fluoxetine has been associated with slower growth in the breastfed baby. In our opinion, while there are occasions when breastfeeding and the feeding of breast milk is not possible because of a contraindicated medication, they are quite rare. Unfortunately, weaning unnecessarily due to inadequate knowledge about medication safety is not uncommon. The potential side effects of receiving breast milk substitutes are rarely considered. Be prepared to provide prescribers with resources for current evidence-based information regarding medications and breastfeeding. Concern: mother is ill. Descriptor: safety of breastfeeding during maternal illness. The illness may be acute or chronic, infective or non-infective. Countries have their own recommendations, especially for HIV-positive mothers or for women who are at high risk for HIV. Appendix Q. Unique identifier. Maternal health conditions may impact breastfeeding, but few are absolute contraindications to breastfeeding. See Appendix Q for a more concise chart from the United States Centers for Disease Control and Prevention. Always consult up-to-date resources. In the United States, breastfeeding is contraindicated if HIV positive and HTLV1 or HTLV2 positive. Breastfeeding is allowed with acute infectious diseases such as respiratory, reproductive, or gastrointestinal infections. Breastfeeding is allowed with acute tuberculosis after 2 or more weeks of treatment. Tuberculosis is communicated via droplets, not breast milk. so separation from the baby may be required. However, collected milk may be fed to the baby by someone else. Okay. If a diagnosis of hepatitis A has been made, breastfeeding can start as soon as gamma globulin has been administered. If a diagnosis of hepatitis B has been made, the infant should receive hepatitis B immune globulin, HBIG, and the first dose of hepatitis B vaccine within 12 hours of birth. There is no reason to delay breastfeeding. If a diagnosis of hepatitis C has been made, breastfeeding plans should not be altered. However, the CDC advises that if nipples are cracked or bleeding, nursing should be stopped on the bleeding nipple until healing occurs. Women with venereal warts may breastfeed. For the herpes viruses, for cytomegalovirus, CMV, breastfeeding the full-term infant is allowed. For premature babies, freezing milk reduces but does not eliminate CMV. For herpes simplex, breastfeeding is allowed except if the lesion is on the breast areola or nipple. For chickenpox, active varicella, infection that developed within the 5 days prior to delivery to the 2 days following delivery, breastfeeding is not allowed, but expressed breast milk may be fed to the baby. For Epstein-Barr, breastfeeding is allowed. For toxoplasmosis and mastitis, breastfeeding is allowed. For Lyme disease, breastfeeding is possible as soon as treatment is initiated. For untreated brucellosis, neither breastfeeding nor providing expressed milk is allowed. Because flu viruses are changing rapidly, the safety of mother-baby contact and breastfeeding should be verified with the state health department and or the CDC. I wish they separated this from like allowed, not allowed. Because in here they mix allowed and not allowed. And that's like, when I'm giving quick advice, this is too much to scan. Ask yourself, are the drugs prescribed for the condition contraindicated when breastfeeding? What other support does the family need to cope with the condition? Watch out for ideas that illness requires maternal-infant separation because the illness can be transmitted through breast milk and or breastfeeding. This is not always the case. What to do about it? Consult with state or provincial health departments, the CDC, or other national infectious disease authorities when there are questions about breastfeeding and illness or disease. Each case must be assessed individually. Contraindications to breastfeeding are rare. Be prepared to identify and share with the healthcare team sources of evidence-based, up-to-date information about safety of breastfeeding to clinicians working with breastfeeding families. What else to consider? Contraindications to breastfeeding, Appendix Q. In our opinion, contact information for your state or provincial health departments, the CDC, and other health authorities are important resources to have at your fingertips. When questions arise about possible contraindications, families and members of the healthcare team need immediate, reliable answers. Concern: new pregnancy while breastfeeding. Descriptor: breastfeeding during pregnancy. Unique identifier: pregnancy begins while breastfeeding. Unique identifier: pregnancy begins while breastfeeding. Ask yourself, is there a history of premature delivery, miscarriage, or threatened premature delivery? If so, the oxytocin medicated uterine contractions associated with breastfeeding may be a concern. In the absence of such history, there is no compelling research that would indicate that low-risk pregnant individuals should wean. What about sore nipples? Sometimes a desire to continue breastfeeding throughout the pregnancy is stated, but nipple soreness is so uncomfortable that breastfeeding cannot continue. Is the baby less than 1 year old? Will the baby be less than 1 year old when the new pregnancy is 4 to 5 months along? It's common that the volume of milk decreases as mature milk becomes colostral in mid-pregnancy. That's good to know. Let me highlight that. So mid-pregnancy colostral milk it's common that the volume of milk decreases as mature milk becomes colostral in mid-pregnancy. Nutritional assessment of the baby's intake will be needed to determine if the baby will need formula supplementation. Watch out for appropriate nutrition for the nurser and the nursling. Some babies have very loose stools when the milk becomes colostral. This is not because the milk is bad, but because colostrum is a powerful laxative. Many worry that the new baby will get less colostrum because the older baby takes it all during the pregnancy. This has not been found to be a problem, as the hormones of pregnancy trigger continued synthesis of colostrum until complete delivery of the placenta occurs. What to do about it? Offer support the family in either choice. Offer to support the family in either choice, to continue breastfeeding or to wean. Ensure adequate nutrition for the nurser, the nursling, and the new baby. Expected resolution. Sometimes families decide to wean when a new pregnancy is discovered. Sometimes families decide to continue nursing throughout the pregnancy. Sometimes families decide to nurse both babies together. Nursing 2 or more children not from the same pregnancy is called tandem nursing. The new baby should be fed first and often. It's important to find time for non-breastfeeding interactions with the older baby. What else to consider? Sometimes it's decided to nurse during pregnancy and go on to tandem breastfeed, but the older baby loses interest when the volume decreases as milk changes mid-pregnancy. When you may be asked about whether a weaned older baby should be offered an opportunity to breastfeed after the new baby is born. You may be asked about whether a weaned older baby should be offered an opportunity to breastfeed after the new baby is born. We advise families to think very carefully about the ramifications of this offer before making it. Many formerly breastfed children may have forgotten how to release milk from the breast, but the family should be prepared for the possibility that the weaned child does recall how to trigger milk flow and wants to return to breastfeeding. Help the family to explore if they would find that to be an acceptable outcome. In our opinion, the improved nutrition during breastfeeding in pregnancy today has made breastfeeding during pregnancy and tandem nursing viable options for many. Concern: weaning. Descriptor: beginning other foods or stopped breastfeeding. Unique identifier: the end of breastfeeding this baby. Weaning can be characterized as one of 3 types. Parent-led weaning: when the parents decide to end breastfeeding. Most of the following discussion refers to this type of weaning. Baby-led weaning, where breastfeeding goes to an on-request only system and follows the philosophy, never offer but never refuse. This is only for babies more than 1 year old. The idea is that the baby gets so involved in a busy life that breastfeeding takes a more and more minor role. Society-led weaning, where everyone in the society weans at the same time, usually after the 2nd year. Weaning is a time for ritual and celebration. Ask yourself, what do I mean when I use the word wean? 1 second. What does this family mean? Okay, what do I mean when I use the word wean? What does this family mean? For some people, the word wean means beginning to stop breastfeeding. For others, wean means that breastfeeding has stopped altogether. Yet others mean continuing to breastfeed while adding complementary foods. It is important to clarify this so that you and the family are using the word in the same way. For example, the statement may be, I'm ready to wean my baby. This could mean, I want to start breastfeeding my baby other foods besides my milk. Or this could mean, I want today to be the last time I breastfeed. Or this could mean, I would like my baby to drop the nighttime nursing. This is good to highlight. What does weaning mean? For some people, weaning means beginning to stop breastfeeding. For others, weaning means breastfeeding has stopped altogether. Yet others mean continue to breastfeed while adding complementary foods. I mean, ultimately, all of those will end to the milk drying up. If the idea is to stop breastfeeding altogether, how fast should this happen? in 1 day, in 3 months, by the time the baby is 1 or 2 years old. Rapid weaning can have negative consequences for the breast, such as breast discomfort, mastitis, and abscess development, and the child, for example, longing for nursing or no longer being potty trained. The faster the weaning, the more watchful everyone will need to be. Watch out for choice of breast milk substitutes. What is appropriate to replace breast milk? For babies under 1 year, formula is the appropriate substitute. How does the baby react to the substitute? Are there any physical reactions? Choice of breastfeeding substitute. The substitute for the closeness of breastfeeding has to be equally good in the eyes of the child. Asking a 9-month-old baby to wean from a breastfeeding by crying it out alone in a crib is obviously not an equal substitute, but having a fun bath time, a sippy cup of water, reading a story, or eating a healthy snack might be. Speed of weaning. It is possible to stop breastfeeding quickly, but the breasts do not stop making milk quickly. Depending on the stage of lactation and milk volume, milk may need to continue to be removed, and the milk supply gradually decrease in order to prevent engorgement, mastitis, and abscess. Emotional responses. With baby-led weaning, sometimes the baby is less interested in continuing the nursing relationship than the nursing parent, who may feel wistful about the loss of their special time together. With parent-led weaning, the baby may feel rejected or ignored and shut down or become demanding. What to do about it? Sometimes those who did not need any help to breastfeed are surprised at how much help and support they need during weaning. Sometimes breastfeeding is ended and the baby cannot tolerate the substitute. See Appendix J for information about relactation. Expected resolution. The breastfeeding time and the weaning time will be remembered with joy, irrespective of the duration. What else to consider? Do not confuse weaning with a nursing strike, which is a sudden refusal of the baby to nurse, even though there is plenty of milk. Strikes are not the same as weaning, but some strikes are never resolved and signal an end to breastfeeding. Babies under 1 year of age rarely wean intentionally. There are many reasons for a nursing strike. For example, baby cannot nurse because of a stuffy nose, baby is teething, baby has an ear infection, baby prefers bottle, baby has bitten the breast and gotten yelling or screaming as a response, scaring the baby. Family stress, separation. The problem has to be dealt with before the baby will return to nursing. Assist with temporary milk expression and an alternative feeding method, e.g. cup, spoon, etc., to deliver milk to the baby. To end the strike, offer lots of skin-to-skin contact. Never force a baby to the breast. If possible, avoid bottles. Try offering the breast when the baby is sleepy. Try bringing the baby to a meeting where there are lots of breastfeeding babies. Babies may respond to the peer pressure of seeing other nursing babies. Sometimes weaning begins and then the parent changes their mind. The milk supply can be built up again if need be. Some people think that the only reason anyone would be nursing a baby for more than 6 months is because they do not know how to wean. In our opinion, in the United States, public nursing of babies older than 6 months is rare, so people may think they are supposed to wean because they only see young babies nursing in public. As breastfeeding becomes more of the cultural norm and is seen more in public, it is our hope that the duration of breastfeeding will increase. Concern: birth control. Descriptor: avoiding pregnancy while breastfeeding. Unique identifier: birth control or family planning methods compatible with breastfeeding. Ask yourself, what are the plans for future pregnancies? How do religious beliefs, health concerns, or lifestyle preferences affect the choices for family planning? What choices are more or less appropriate while breastfeeding? Watch out for misunderstanding the relationship between breastfeeding and fertility. Some people believe that you can't get pregnant when breastfeeding. That's not true. Not true, but really not true, because I've had a lot of babies born immediately after the first birth. I have recently had a client like that, so be aware. Hormonal methods of birth control containing estrogen, these are not recommended in early lactation. Starting progestin-only types of birth control too early. For example, the package insert for Depo-Provera suggests starting in the 6-week postpartum in breastfeeding women. What to do about it? Progestin-only forms of birth control are options while breastfeeding after the early weeks. These include birth control pills, injections, and implants. All barrier methods, including cervical caps, condoms, diaphragms, foam, and so on, are acceptable while breastfeeding. Note that breastfeeding may result in vaginal dryness, and intercourse may be comfortable when additional lubrication is used. Carefully explore the options, including the lactation amenorrhea method, LAM. See Figure 9.1. Research studies indicate that the cumulative pregnancy rate using LAM is similar to that of other types of birth control. Expected resolution. The method of birth control or child spacing will meet the needs described and be compatible with breastfeeding. What else to consider? Learn about the availability of books and classes for parents on other methods of child spacing, such as symptothermal method or natural family planning, a combination of calendar rhythm, basal body temperature, and other techniques. Actually, there is a book, Taking Charge of Your Fertility. I've been using it for years. It is a really fundamental book about natural family planning, and it teaches about the calendar, using the calendar, the basal body temperature, and it's really helpful to really measure day by day. So it's called Taking Charge of Your Fertility. So now I'm going to go over this chart that's in here, Figure 9.1, lactational amenorrhea method, LAM. And it says it's modified from LeBuck M., Cooney K., and Coley S., 1994. Guidelines: breastfeeding, family planning, and the lactational amenorrhea method, LAM. Washington, D.C. Institute for Reproductive Health. And so this chart, it says menses, yes, the mother's chance of pregnancy is increased. For continued protection, advise the mother to begin using a complementary family planning method and to continue breastfeeding for the child's health. Menses, no. Supplementing breastfeeds regularly, yes, the mother's chance of pregnancy is increased. Supplements breastfeed regularly, no. Baby older than 6 months, yes, the mother's chance of breastfeeding of pregnancy is increased. Supplements breastfeeds regularly, no. Baby older than 6 months, no. 1 to 2% chance of pregnancy. When the response changes to yes, then the mother's chance of pregnancy is increased. So, read the book. In our opinion, birth control options are not thoroughly discussed in relation to breastfeeding plans, so families may think that breastfeeding is not compatible with birth control or that breastfeeding provides complete birth control. Not true. When I meet with my families, I always talk about birth control, breastfeeding as part of the postpartum discussion is always discussed. So I recommend that you do as well. Concern: breastfeeding multiple babies, twins, triplets, and more. Descriptor: breastfeeding multiples. Families who are anticipating the addition of multiple babies may be concerned about whether breastfeeding is possible. It is possible to make enough milk for many babies, but the situation is often complicated by prematurity and concerns about milk supply. Unique identifier: breastfeeding twins, triplets, or other multiples. Ask yourself, were the babies born prematurely? Was there bed rest at the end of pregnancy? After bed rest, there may be muscle atrophy and fatigue. These conditions do not influence milk supply, but it may influence the ability to cope with the stress of multiple, often premature babies. Are the babies able to transfer milk? What resources, physical and emotional, are available to the family? Watch out for lethargy, decrease in urine and stools, change in breastfeeding behavior, problems with feeding. What to do about it? Nursing babies simultaneously is helpful for building a milk supply, but may be difficult to manage at first. Offer help with positioning. A variety of positions shown in Figure 9.2 work well with multiples. At first, switch the babies from one breast to the other. As the babies get older, they may prefer nursing on one breast or the other. Many families have found it helpful at first to write down who nursed when to be sure when that each baby gets enough. Undertake a feeding assessment. Expected resolution. There is no way to know ahead of time how much milk it is possible to make. Frequent weight checks of the babies are needed to assess growth in the early weeks. What else to consider? Encourage the families to keep an open mind about the baby's feeding plan. Sometimes a plan to pump and feed bottles is found to be more work and take more time than feeding only at the breast. In our opinion, simultaneous nursing is very helpful in ensuring an adequate milk supply. It is important to have weekly or more frequent weight checks of the babies to ensure that all of the babies are thriving, especially with higher order multiples, 3 or more babies. There is no reason to expect that enough milk cannot be made for multiples, given early and adequate stimulation, milk removal, and support. And this is figure 9 too, with all the different support for multiples. Interesting. Figure 9 2. There are several positions that work well for simultaneous feeding. Concern. Let me get a cup of water somewhere. Concern. Lactation in transgender individuals. Descriptor. Lactation in individuals whose gender identity is different from the sex assigned at birth. Unique identifier. Lactation in transgender individuals who may or may not have given birth. Ask yourself, what are the pronouns used by this person? He, she, they, they. What is the term that they would like you to use to describe their parental role? Inquire respectfully about this and use the preferred pronoun and descriptors. What is the desired outcome for this individual? Is it chest feeding, breastfeeding, milk expression for feeding away from the chest or breast, or the reduction of milk production quickly and safely? What support is needed to achieve the individual's expressed goals? How can the multidisciplinary team support these desired goals? Has there been surgery to the breast, chest? If so, see pages 44 to 46. Is there a desire to continue or resume hormonal protocols? Both testosterone and estrogen are incompatible with milk production, but not with supplementary feeding using a feeding tube device. Appendix N. Is there a desire to use a binder around the chest? Compression reduces milk production and can be a precursor to clogged ducts and mastitis. Is there a desire to produce milk when there has not been a pregnancy? Induced lactation. Appendix J. Is there a desire to stop lactation as quickly and safely as possible? Water baths. Page 69. Binding and pain inflammation relieving medications can help as milk production is reduced. Watch out for assumptions about parental roles and desires based on cultural expectations. What to do about it? Remember that there is little biological difference between male and female breast tissue in innervation, etc. Strategies used to support the initiation of milk production and to increase and decrease it are the same regardless of the gender of the individual. Expected resolution. Transgender individuals should be able to breastfeed, chest feed, or neither, depending on their desires and goals. In our opinion, when the sex assigned at birth and the identified gender diverge, anxiety, gender dysphoria, and distress may be heightened around the events of pregnancy and lactation. Offering sensitive, individualized care is key. Everyone deserves optimal care. Concern. Tongue and lip tie. Descriptor. Restriction of the movement of the tongue or upper lip. Concerns have been raised about whether babies who are born with tongue and lip restrictions can breastfeed. Unique identifier. Concerns about whether breastfeeding problems such as nipple pain and fissures, mastitis, poor growth, etc. can be explained by lingual, tongue, or labial lip restrictions, ties. Ask yourself, has a detailed individualized breastfeeding assessment been completed and corrective interventions implemented? Watch out for thinking that releasing the restriction of the tongue and or lip is the most expedient solution for breastfeeding problems. I just want to pause there because there is, as the book says, and as you'll hear in the sessions and elsewhere, the whole lip and tongue tie, there's a lot of controversy around whether that's even helpful. It's kind of been the go-to thing for doctors to perform. It's a relatively simple, not without pain, but the baby is numbed enough. But the fact of the matter is that doing a cut is not helping these babies, and so it's a money maker, but it's not actually helping babies, and the evidence is showing that. So, what to do about it? Suggest options for improving breastfeeding latch and feeding, especially the top lip rolling in, mouth not opening for more than 140 degrees, and the latch not being asymmetrical. Refer as needed if diagnosis and treatments are not within your scope of practice as a lactation care provider. Ensure that the baby has had the time-release vitamin K injection after birth if the decision has been made to revise the tongue or lip anatomy. Breastfed babies do not reach adult levels of vitamin K until around about 6 months of age if they don't have the injection after birth. This makes them vulnerable to uncontrolled bleeding. Even young babies who have had the vitamin K injections have been hospitalized because bleeding could not be stopped after a tongue revision. So this is another thing for the parents that are, they don't want to vaccinate and they are afraid of the vitamin K shot. This is a prime reason why we have to strongly suggest the vitamin K shot. I've been at so many types of births, different ideologies, but the vitamin K, the midwife always presses that the baby needs the vitamin K to prevent the loss of blood. Expected in blood clotting. Expected resolution. According to research, dyads with breastfeeding problems attributed to tongue and lip restrictions should first get a complete breastfeeding assessment, and the suggested corrective interventions should be implemented. In our opinion, research does not support revising tongue and lip restrictions as the first intervention for breastfeeding problems. Rather, a comprehensive pediatric exam, breastfeeding assessment by a multidisciplinary team, including oral motor specialists, should be the first step, even when there is an indisputable restriction of the tongue or lip. And I'm going to highlight this. Vitamin K injection. If they don't have the injection after birth, that makes them vulnerable to uncontrolled bleeding. Because they don't reach vitamin K until about 6 months. Breastfed babies do not reach adult levels of vitamin K until about 6 months of age. Now, I don't know if formulas are fortified with vitamin K, but we probably need to stress the importance of vitamin K. So with that said, that's the end of section 9. And now the next time I meet with you, I'm going to go through all of the appendices. I'm going to go one by one. Some of these appendices are very short, so it might be 5-minute videos, but I'm doing it in this way so that it's easily digestible and you can refer to each one by one rather than trying to have to sift through a large video. So with that said, thank you for watching and listening, and I hope you have a great day.